Coco, how are you?
Ah,
Long time
I'm
no
doing
see.
great. How are you?
See. Yeah,
Thank you very much for having me today.
yes, I'm sure you're in Tokyo now. And then let me just spend 2, 3 minutes explaining to you what is the program we are running. And then we'll go ahead to our interview. So actually we are running this program, we call it interview the first offer, because the first offer usually is the one implement the study. So we wanted to understand a little bit like more technical detail or new insight behind the paper, because the paper
Mhm.
is only 3,000, 4,000 words. They may not have
Yeah.
the opportunity to share with us the details and a lot of like thinking behind it. So
Mm,
we have been running this interview the first offer for a couple months. And then we
I
have
see.
interviewed Toji Ho in Hong
Yeah,
Kong Polytech, and
yeah.
also a couple of other myopia researchers as well in Hong Kong and
Mhm.
in Singapore.
Yes,
So first of all, thank you very much for taking your precious time to join our
yes. Thank
program.
you very much. It's
And
my
then,
pleasure.
yes. So can I just start from your self-introduction? Just tell our audience a little bit who you are, how long have you been working on pathology myopia or high myopia research and clinical service as well?
Okay, thank you so much. I'm Kyoko Ono Matsui from the Department of Ophthalmology and Visual Science at Tokyo Medical and Dental University. I'm a professor and chairman of the department, and also I'm the director of the Advanced Clinical Center for Myopia, which specializes in pathologic myopia. And this center accommodates more than 6,000 patients with pathologic myopia from all over Japan and from overseas sometimes. And actually, I have been involved in practice of pathologic myopia for a long time. I joined the high myopia clinic at maybe nearly 30 years ago, when the honorary Professor Tokoro was a chairman. And when I joined at the high myopia clinic, there were no treatments available. So we just observed, we just followed the patients. But many patients were our clinic periodically without hesitation, and I have been soon attracted to this disease. And recently, many different kinds of imaging have emerged, and pathologic myopia is a really good disease for imaging. I like seeing those patients, and I'm happy about the recent advance in imaging and also treatments.
Fantastic, Coco. Yeah, I understand you got probably the longest follow-up cohort for myopia and pathology myopia in the world. Like, because by looking at your paper that you publish, I think you talk about like 30 years follow-up. It's really long. And then that really allow us to observe what's happening in pathology myopia. So let us
Yeah.
start from a little bit. What is the definition of pathology myopia? Can you tell us a little bit what is that Meta PM group, and then what's your idea or insight like to set up some proper definition system for pathology
Yeah.
myopia?
Yeah, thank you very much. Meta PM study group was established at 2014. I'm not so exactly aware of the year, but myopia specialists got together and tried established new classification, and it classified uh, myopic maculopathy lesions into 5 different categories, like tessellated fundus, diffuse atrophy, patchy atrophy, and myopic macular neovascularization and macular atrophy. And this is a very clear classification. And pathologic myopia is considered myopic eyes having myopic atrophic lesions equal to or more serious than diffuse atrophy or eyes with posterior staphyloma. And this definition is unique because we defined pathologic myopia by the presence of myopic fundus lesions, in addition to the presence of myopia. This definition differentiates pathologic myopia from other high myopia, but without pathologic myopia.
Fantastic. So because clinically it's important to differentiate high myopia and pathology
Mhm.
myopia. But in real practice, do we really understand how this pathological changes on the retina or choroid might develop. A conversion from high myopia to pathologic myopia. Do we really understand what is the mechanism, and also what is the proper treatment that would really slow down this conversion from high myopia to pathologic myopia?
Yeah, that's a really difficult question. We recently used ultra wide field OCT. This device can non-invasively detect staphylomas, even in children. These results show that some children already have staphylomas at a very young age. So it may suggest that children who become pathologic myopia may be different at the beginning, or pathologic myopia may start at a much earlier age than we previously thought. But it is true that highly myopic children without staphloma or without pathologic changes also become pathologic myopia in a later life. What occurs first in this progression is not fully clear, but one clue is the choroidal thinning, especially around the optic nerve. And the choroidal thinning is very extreme, and sometimes it's local, only around the optic nerve. So it's not a generalized and uniform thinning of the choroid. But this local absence or extreme thinning of local choroid may be the beginning of pathologic myopia. And Professor Just Jonas also said Brooks membrane may play an important role, and a defect of Brooks membrane may trigger the progression to pathologic myopia. But this is a very important point. So we, through a thorough examination of many children with high myopia and a long follow-up, may reveal what happens and how it progresses to pathologic myopia. But the treatment is really difficult. At this point, we cannot thicken the choroid. Maybe you can do it with your red light therapy, and if we can thicken the thin choroid, it may be important. And also we are looking for treatments to prevent and treat staphloma. And scleral thinning may come first before clear development of staphloma. So we are looking for scleral collagen cross-linking or scleral regeneration. And so scleral targeting therapy may be another hope.
Yes, maybe we go back to treatment and therapy later on. So going back to staphylomas, I think a lot of ophthalmologists really feel like pathologic myopia is so interesting because this is really one of the eye diseases, or maybe the only one eye disease that can change the ocular shape, the shape of the eye. So what is your insight into like understanding what is the best strategy to examine and observe the staphloma and the change of the ocular shape, for example?
Thank you so much. We used to use 3D MRI technique, and you used it too. And I think this is a great technique because we can observe the entire shape of the eye. Sometimes in eyes with deep staphloma, the entire shape has changed. And sometimes ocular wall around the staphloma may flatten than normal eyes. So I think it is important to observe the entire eye shape. And also measurement is possible. We can measure the eye volume and probably staphloma volume. So quantitative measurement is possible with this device. But it is still difficult to screen, to use this device for so many children as a screening technique. It takes time and it is expensive. And for that purpose, we use ultra wide field OCT. And this device is now commercially available with Canon in some countries. And I think Zeiss has similar device. And with this device, non-invasive visibly, we can observe the wide area of fundus. And for the detection of staphloma, I think detecting staphloma edges is really important. And some researchers were confused with generalized bowing of sclera as staphloma, but the generalized bowing is caused by axial elongation. So to detect staphloma, detecting its edges is really important because staphloma is a protrusion of a certain area of the fundus. So I think at this point, ultra wide field OCT may be the best tool to detect staphloma. But for qualitative diagnosis is okay with this device, but for quantitative measurement of staphloma diameter, staphloma depth, I think maybe some modification is necessary because the peripheral image is somewhat distorted.
So what you say is like the conventional fundus camera, like 45 degree or 50 degree is not sufficient for staphloma observation. And then, yes, my question is, how about optos, like an ultra wide retina fundus camera? Yeah, would that be feasible or appropriate for this staphloma in terms of identifying the boundary or the margin of the staphloma?
Yes. First, conventional 50-degree fundus photo is not enough to detect staplomas because the most common staploma is wide type, and it is beyond the border of 50-degree fundus photos. So we can't see staphloma edges. We may see a diffuse atrophy or tessellated fundus, but we don't know it's caused by generalized bowing or staphloma. And Optos, a wide field fundus image, is really useful. And one time we compared the detection of staphloma with Optos and 3D MRI, and it corresponded well. So I think Optos is a great opportunity, and especially Optos has a different color, a pseudo color and infrared and autofluorescence. And when we combine these different methods, we can increase the detectability of staplomas. But one problem is that Optos shows the pigmentary changes occurring at staphloma edges. So when staphloma deepens and when the staphloma edges damage RP on the edge, it can be observed with Optos. But for example, in early staphloma, without any significant RP damage on the edges, it may be difficult to detect such early and mild staplomas.
Oh, I see. Also, you just raised an important concept. We got to differentiate general bowing and staphloma, like a localized bowing. Yes. Do we really understand how this staphloma developed? Why a lot of high myopia children or adults, they have a general axial elongation or general bowing, but then only in some of the people they develop staphloma. Yes. So do we actually understand what's the mechanism for this development of the staphloma?
Yes, it's a really important question, and it's the core of staphloma. And we took a look at many 3D MRI images of our patients with pathologic myopia, and sometimes eyes without staphloma were really big. In other words, their eyes can become really big. The other eyes cannot become very big, so their probably Bruch's membrane have to tear in some areas. So some balloons can become really large, but some balloons with a rupture. I'm not sure which tissue is responsible, but I probably think a Bruch's membrane can be stretched really well in some patients, but they cannot be stretched in other patients, and maybe some tears occur. And once tear occurs at some points, very large areas starting from that area protrude. I think that may be a reason. So we now analyze a wide field OCT images from different age group, from children to elderly and try to see where and how staphyloma occurs, or how the Brooks membrane status is. But this is a lot of work, and still we haven't found it yet. But in addition, we measured eye volume with 3D MRI, and we found that the highly myopic eyes without staphyloma and highly myopic with staphyloma did not have significant difference in eye volume. So probably how large eyes can become maybe set, and there is a maximum limit for that. I'm sorry, I cannot give you a clear answer because this is a really important question, but a difficult question.
I think a lot of clinicians, they also very interested in understanding, in Japan, do you perform this scleral buckling for staphyloma treatment? Or like if you got children highly progressive, there's no way to stop this progression or staphyloma. Do you perform scleral buckling, or how common is this practice in Japan?
Yeah, I think this is a very interesting procedure, and I know that some researchers in Japan conducted this procedure, but unfortunately, scleral buckling, macular buckling, is not commercially available here, so we cannot do that anymore. But as you mentioned, I think thickening sclera and prevent the protrusion of sclera in children is really important for pathologic myopia, because if once staphyloma occurs, it may be too late, and it's difficult to protect and treat nervous tissue, but we may prevent the protrusion. We may be able to treat the sclera before staphyloma occurs, and I think it's an ideal goal for treating pathologic myopia.
Yes, thank you so much. And also for my pathologic myopia control, we talk about how to slow down the myopia progression among the highly myopic children. So in our clinical practice, assuming if you see a patient 7 years old, high myopia, -6 diopters, so how do you normally manage patient like this? It's like an early onset high myopia patient. So
yeah.
Is your clinic managed patient like this?
Yeah, actually, our myopia center has three divisions. One is pathologic myopia. The next one is children myopia, and the third one is refractive surgery. And the children division is the director of that division is Dr. Tae Igarashi,
Yes.
and she takes care of many children. And but in Japan, we have fewer options to treat childhood myopia or high myopia. We can prescribe low-dose atropine, and we can do also keratology and multifocal contact lenses, but we don't have special design of glasses like DIMS lens or Essilor Stellest lens, and your amazing red light therapy. So I think it's important to stop or slow the progression of myopia for these highly myopic children, because myopia progression is a trigger of the progression to pathologic myopia. So I hope we have more options, especially red light therapy in the near future. But yes, this is what we can do now.
Thank you, Kyoko. So your work is mainly to control like the pathologic myopia progression.
Yes, that's right.
So can you share with us a little bit like more on what's your protocol in terms of anti-VEGF treatment, like Lucentis and all this treatment, intravitreal injection treatment for the pathologic myopia patient or in the elderly population? So what is the protocol?
Thank you so much.
Do you do this injection for everybody, or what's the indication?
Yes, actually, we think for myopic maculopathy, neovascularization is the biggest cause of central vision loss. We diagnose neovascularization, and we detect the activity. And for active neovascularization, we do anti-VEGF therapy. It is a first-line therapy. And but around half of the patients receive one injection alone, and half of them their neovascularization regresses with a single injection. So we just inject one time and check them 1 month later and 3 months later. And if the neovascularization recurs, we re-inject. But we still use OCT. In addition to OCT and OCT angiography, we still use a lot of fluorescent angiogram and ICG angiogram, dye-based angiogram, because it is easy. OCT angiogram is sometimes not clear in eyes with pathologic myopia with lots of atrophies, and the dye leakage in angiogram is still easy to see and useful. So we have a big collection of dye-based angiogram. So I think choroid is affected first. So we are now trying to look at ICG angiogram also. So in this clinic, we do so many examinations, especially at the initial visit. Wide field fundus, wide field angiogram, everything wide field OCT. And I hope someday this information may be useful. But we do a lot of injections.
Fantastic. You mentioned you have been doing a lot of fluorescing, FFA, ICGA, or even wide field one. So so all this purpose is to mainly to observe or discover CMV, the existence of CMV. So for those patients without CMV, so would you still treat with intravitreal injection? I mean, with pathologic myopia, for example, patchy atrophy and
no, actually we don't. We only inject anti-VEGF to neovascularization patients. And yes, that's right. And in emmetropic patients, when macular bleeding occurs, it is highly likely that they have AMD. In eyes with pathologic myopia, there is another condition called simple hemorrhage without neovascularization, and we experience some clinicians inject anti-VEGF for this condition as well. So we try to differentiate the macular bleeding with and without neovascularization. And we inject anti-VEGF only for neovascularization patients.
Oh, I see. I understand there's two clinical trials working on this MCMV, myopic CMV in particular. So in your understanding, with and without anti-VEGF treatment, would this have better outcome in terms of preventing this CMV-related atrophy happening? What was the long-term effect on preventing this?
I agree with you. And as you mentioned, and in the long term, more than the recurrence of neovascularization, macular atrophy development around the neovascularization is at the cause of vision loss. The clinical trials data were fascinating, but in the long term, in a real world, the vision decreased maybe 4 years and 5 years after the onset because of the development and enlargement of macular atrophy. And it is a great important issue because the patients with pathologic myopia develop neovascularization at a younger age than AMD patients. So they develop neovascularization in their 50s or 60s. So the 5-year or 10-year outcome is really important for them. And but compared to even with anti-VEGF therapy, macular atrophy develops in the long term. But compared to natural cause without anti-VEGF therapy, the neovascularization shrinks with anti-VEGF therapy, and in parallel, the area of macular atrophy, which later occurs, is smaller in eyes treated with anti-VEGF therapy. Still, this treatment is useful to slow down the progression development of macular atrophy. So the vision declines, unfortunately declines in a longer term, but still slows the decline compared to natural cause.
So in your clinical practice, you're seeing a patient with, for example, patchy atrophy, diffuse patchy atrophy, and then how frequent you perform FFA, ICGA, or do you do you just wait for the compromise of the BCVA? If the patient got sudden loss of best corrected or their visual acuity vision, then they come to see you, and then you see the macular hemorrhage, and then you do and then you consider FFA, or you just consider FFA ICGA frequently, like maybe once a year. Or what's the protocol in terms of
actually,
CMV?
yeah, thank you. Actually, invasive examinations like the dye-based angiograms are only done at the initial visit. And if necessary, we repeat these examinations, but otherwise we don't do examination except for the initial visit. And for follow-up intervals, maybe patients who need treatments like under-visual therapy, we see often at least in 3 months, every 3 months for the first year. And for the second year, we need to detect the macular atrophy. So 6 month interval, we check autofluorescence to detect macular atrophy. And for the patients with no problems, for example, for patients with sporadic patchy atrophy and the central vision is okay, we check them maybe every 6 months. And actually, we also perform Goldman perimetry frequently, at least once a year, because so many patients develop glaucoma. And glaucoma diagnosis is really difficult in eyes with pathologic myopia. So we frequently use Goldman perimetry and match the visual field defects can be explained by fundus lesions. We check this correlation, and if there is no correlation, we suspect the optic nerve origin.
And also in your clinical practice, how do you manage the MTM, the myopic tractional maculopathy? How do you manage, for example, schisis and I mean this MTM problem?
Yes, we see many MTM patients as well. And when they have foveal retinal detachment or macular hole, we immediately perform vitreous surgery. And for the patients with macular retinal schisis only, if the height of schisis is not so large, we just observe. But the height of retinal schisis is as high as the retinal thickness itself. So in other words, retinal thickness becomes double the mechanical load onto the outer retina reaches the nearly maximum. And sooner or later, foveal retinal detachment happens in these eyes. So another surgical indication is when the retinal thickness becomes double. Even though the vision is good, remains good, we consider surgery because after developing foveal retinal detachment, some visual impairment may remain. So these days we try to operate on them earlier than before.
I see. And do you observe all this significant visual best corrected BCVA improvement after MTM surgery, like the vitrectomy or scleral surgery? Improvement on the BCVA, yeah.
Yes, we observe the improvement of BCVA, and we also check microperimetry and check the fundus sensitivity. Yes, in the spot, because sometimes the central visual field improves, but sometimes there may be scotoma in the subfoveals around the fovea. We try to detect such scotoma caused by surgery, and also the central improvement of sensitivity in the fovea. So we use both visual acuity and microperimeter.
Yes, and again, in terms of the scleral staphyloma management, you mentioned scleral buckling is not that common. So in your understanding, any people try to working on this cross linking on the scleral at the moment? Did they achieve any success on this scleral treatment?
Yeah, actually, with Santen pharmaceutical company and with the governmental support, we are now trying to start clinical trials to treat staphylomas with scleral collagen cross-linking. It may be the first patient recruitment will start within this year, I guess. And I hope this succeeds well. But I don't know other researchers who are working on who are using scleral cross-linking on humans. There are many studies using animals, but I'm not sure other researchers working on this.
Yeah, fantastic. Kyoko, and again, I think we did a lot of great jobs on observing pathologic myopia development in a very long term, 30 years, 20 years. I understand this pathology changes, like the macular, we call it myopic MMD, degeneration. Most of the time occur after 40 years old. And as you mentioned, some of the changes like diffuse atrophy or even mild staphloma can happen in a very young age group, very young patient.
Yes.
So, but then in terms of the controlling this MMD progression, at the moment, there's no treatment available. So, and in China, we're working on this red light, as you mentioned, red light treatment. And then we prove that with the red light really is the first intervention that you can reliably increase the choroidal thickening.
Yes.
Choroidal thickness. Yes. So this choroidal thickening would mean significant increase on the blood flow on the choroid. And also in some of the experiment, also with the high dose atropine, for example, 1% atropine, they also induce the thickening of the choroid as well. So how do you foresee this treatment that is able to increase blood flow or choroid thickening may contribute to better treatment for pathologic myopia?
Yeah, I think it's really important because we see that the choroidal thinning, especially around the optic nerve, occurs earlier than staphloma development. So if we can increase the choroidal thickness, especially around the optic nerve, it would be a useful method to prevent later development of scleral curvature changes. So we would like to see if that happens. And so I'm very much looking forward to your red light therapy and choroidal thickness changes accompanied with that, obtained with that.
Yeah. And also still remember your paper publishing, I think you are one of the first report the choroidal thickness changes among tessellated retina, diffuse atrophy, and also among this, we call it optic disc atrophy and macular atrophy. And you report the significant choroid thinning if you have pediatric atrophy, of course, but also if you have macular diffuse atrophy as well. So this is all the great work. I mean, we have been learning a lot from your research. Can you share with our audience a little bit, what is your current research project on pathologic myopia in terms of like imaging and or maybe a new treatment? I mean, if it's not confidential, I mean.
No problem. Yes. Thank you so much. As you mentioned, I think staphloma is a really important core of pathologic myopia. And when and how and where staphloma occurs is really important because although staphloma includes a wide area, I think the first change occurs in a small area. And this small area change spreads, enlarges with time. So if we can identify the first change with a less invasive treatment at an earlier age would be possible. So for that purpose, I would like to analyze all wide field OCT image in a very different age with a follow-up. And that is ongoing. And also, I think it is interesting to know that many changes, choroidal thinning, scleral curvature changes, seems to start around the optic nerve. And also optic nerve damage is really a big cause of vision loss in patients with pathologic myopia. And other areas of sclera other than optic nerve is kind of a uniform structure, but in the optic nerve area, nerve tissue penetrates the eye and there is lamina cribrosa. So I think this area, optic nerve and around the optic nerve is a fragile tissue when the eye extends, elongates. So what happens around the optic nerve may determine the later change. So, but I think choroid is really important. And where the sclera, in the area where sclera protrudes, choroid seems thickened. No, bows posteriorly, choroid thickens. And where sclera protrudes anteriorly, choroid thins. So the choroidal thickness and scleral curvature are really correlated with each other well. And choroidal thickness, increasing choroidal thickness, I think is a great method which we can do in early days of pathologic myopia.
Fantastic. I think all this pathologic myopia research will require very long time follow-up because it develops so slowly. So it really lifelong pursuing. We really admire your work, pathologic myopia, because a lot of work has been, really working on the patients for like based on observation like 30 years. And then in China, we're also working on a high myopia cohort for about 10 years. So we have a couple hundred patients data. So we are very looking forward to work with you and collaborating with you and to analyze data together. And that we hope this will create a new insight or new understanding on pathology myopia. And because I understand time's almost like 30 minutes now. Yeah, so I've been learning a lot from you, Kyoko, in this conversation and interview. So
thank you.
So thank you so much for your time.
Oh, thank you very much for having me today. It's really a great honor and a pleasure for me. And I'm so excited about collaborating with you a lot now and in the near future. And thank you very much today.